Welcome, everyone. I'm Kathy Scrimshaw, and I'll be your moderator today for our session with Dr. Christy Sutherland. Before we get started, we have some housekeeping we need to do. First of all, this is a live recording, and it is being recorded, as you can see. By participating, you understand and consent to the session being made available for ACFP webinar registrants. Recordings are going to be used in the future for videos in our content library on ACFP networks, and also can be used for other CPD opportunities. By participating in the chat and in the live Q&A, you are acknowledging that you understand that privacy. I'm speaking to you today from Beaver Mines, Alberta, which is part of the traditional and present day territory of Treaty 7. I do recognize that we are webcasting from and to many different parts of Alberta today. The province of Alberta is located on Treaty 4, 6, 7, 8, and Treaty 10 territories, as well as the Métis settlements. It is a traditional meeting ground and home for many Indigenous peoples. Please take a moment to reflect on what truth and reconciliation may mean to you, and consider some of the calls to action from a webpage on the ACFP website that has some resources that you might want to consider. Today is the start of Indigenous Peoples Month, and Alberta Health Services also has a virtual program that's going on that you are welcome to join. Next slide, please. So, as I said, I'm Kathy Scrimshaw. I'm a family physician. I am a part-time paid employee of the Alberta College of Family Physicians, and I also work in the Indigenous Wellness Corps for Alberta Health Services. Next slide. The Collaborative Mentorship Network's Virtual Collab Forum series receives financial support from the Alberta College of Family Physicians through a Health Canada Substance Use and Addiction Program contribution. It does not receive in-kind support. Next slide, please. And so it gives me great pleasure to welcome Christy Sutherland back to our collaboration forum. She is a family physician and a diplomat of the American Board of Addiction Medicine and received her MD from Dal University. She completed her family medicine residency in 2010 at UBC and is a clinical assistant professor there now. She is the medical director for the PHS, Community Services Society, a nonprofit based in Vancouver's downtown east side, and it provides care for vulnerable populations. She's leading a team of physicians and nurses, and I imagine others in low barrier harm reduction projects. In 2018, Dr. Sutherland was the British Columbia Family Physician of the Year. She's received many awards, including Excellence in Clinical Teaching Award from St. Paul's Hospital. She's had Gold Corp Addiction Medicine Fellowship, and throughout her career, she's had many research projects and research grants, and very innovative initiatives focused on improving lives of vulnerable populations in the downtown east side of Vancouver. So welcome back, and we're looking forward to your presentation.
I'm so glad to be here. Yeah, I'm here in Vancouver and working in the downtown east side. So that is really what my conflict of interest is. The PHS does pay me to be the medical director, and I've been in the downtown east side for 13 years, and I'm very grateful to all of my patients and all of my coworkers down there. And it's touched my heart to work in this community, and it really has changed me. For research, I do engage in research that's CIHR funded. Some examples are Optima, Presto, and the IOT cohort study, among others. I've never had any relationships with pharma, patents, boards, no pharma funding research. Specifically for the program I'm going to describe here, this is a new formulation of fentanyl that the PHS team created in partnership with our pharmacy colleagues. So it's very off-label use of this drug. We do not make any money from this drug. The staff, the organization, we are not patenting it. It is, we're a nonprofit, so we aren't making money if this intervention is taken up across Canada. And creating this new fentanyl formulation was funded by SUAP. Okay, so we all, I think, as clinicians who are working in this field know what a terrible nightmare this has been. Sadly, April was the 31st consecutive month in BC in which 150 people had died, and the 13th month in a row in which there were more than 200 deaths. It's probably a gross underestimate, but the total number of deaths in April is about 6.9 people every day. So it's really unfathomable how many people have died. It's a very common cause of death. Here we can see in BC that illicit drug death is more than suicide, motor vehicles, homicide, and prescription drug deaths combined. In Canada overall, more than 34,000 people have died, but this is also an underestimate. Some provinces are quite far behind in tracking, and some report no overdose deaths at all, which is obviously wrong. This is a huge cost to Canada. So drug enforcement and Canadian taxpayers around 2.3 billion annually. We are still arresting a lot of people for drug possession, and much of those arrests are for personal possession. And right now, drug supply, drug distribution, and profit from selling drugs is all controlled by organized crime. So, how did we get here? Why is this the system we have? And this is something I've done a lot of thinking about over the past few years, because I've done so many overdose interventions, and I am not very good at acute medicine. It's why I went into community primary care. I don't really like acuity. I like talking with people, very chatty with my patients. And so every time I would do an overdose, I would think, oh, if only I could rewind 10 minutes and give this person something that wasn't poisonous to overdose them. And then I thought, okay, well, if I've got this time machine, why don't I go back to the 80s and have them not be in foster care being sexually abused? And then I thought, okay, well, why don't I go back to the 60s and prevent the 60s scoop from happening, and residential school kidnappings of all these young children, all this horrific nightmare of trauma that I see in my patients now. And then I thought, okay, well, if I've got a time machine, how far back do I actually want to go in this time machine? And so then I started looking into the history of drug policy in Canada and the mapping out sort of the steps Canada took to get us to where we are now. And so we can see a history of drugs becoming more and more illegal, bigger laws, harsher laws, more encompassing laws over the last 110 years, much of it based on racism. And within that march, that drug use has gotten more dangerous. So a lot of times, the public might think that drugs are illegal as the baseline, that that's a reasonable thing, but drugs were illegal until pretty recently. So Susan Boyd is a wonderful scholar here in Vancouver. She said Vancouver is the birthplace of prohibition in Canada, driven largely by anti-Chinese racism and a perceived threat to white middle-class purity. So in 1907, there was riots in Vancouver where thousands of white people went to Chinatown. They destroyed businesses, destroyed homes, and it made international news. The federal government sent a delegation from Ottawa to investigate what was happened, and they met with mostly white individuals who reported the reason for the riots was opium. So this group returned to Ottawa, and they passed without any debate the Opium Act of 1908. And that marks the first time that any drug became illegal in Canada. And then over the coming decades, opium dens closed, drug use shifted to heroin, it shifted to IV, it shifted to fentanyl, it shifted to carfentanil, it shifted to fentanyl with xylazine. This nightmare is only getting worse. It's called the iron law of prohibition. So we can see that Canada has signed on to international and national treaties about drug law enforcement. We actually have quite harsh drug sentencing and punishments here in Canada. The National Anti-Drug Strategy in Canada was in 2007. $67.7 million were spent on mandatory minimum penalties enacted. Mandatory minimum sentencing has never been shown to decrease drug use. It has not been shown to increase public safety. It is an ineffective intervention. In 2007, they abolished or tightened parole criteria, reduced credit for time served, and reduced the use of conditional sentencing. So it gave the judges less discretion. When we look at funding breakdown, 70% went to law enforcement, only 4% to prevention, 2% to harm reduction, and 17% to treatment. So if you had, a blank paper, this is not how you would divide up funding for thinking about drugs and society. So More Harm Than Good is a great textbook. It's a short read, and it says many socially constructed ideas about drugs have been codified into laws that govern how we may access and use these same drugs. So this really resonated with me, because to think about opium dens being closed, that heroin is a prodrug, right? Heroin doesn't act on a receptor, it's metabolized into morphine. So it's diacetylmorphine is the name of heroin. And that long-term side effects of heroin are low testosterone, some bone mineral density loss, and dysphoria. Whereas when we think about alcohol, the molecule itself causes cancer, causes dementia, causes liver failure. So if we were to pick what's legal versus illegal based on the drug safety profile, we would not line it up how it is right now. But if we were to do it based on racism, that's how we ended up where we are. In 1969, the government commissioned an inquiry to look into drug policy. This group of citizens advised that criminal sanctions against people who use drugs be reduced, the offensive possession of cannabis be repealed, that opiate users should be offered medical treatment instead of criminal punishment, and none of these recommendations were implemented. So this seems like a new conversation to talk about drug policy reform, but it's actually been talked about for decades because it's going badly for decades. One of the troubles with talking about this, I think, is that there's no central document that you can just read and say this is drug policy in Canada, because it's multi-jurisdictional and it will pop up in surprising places. So usually people think about the justice system when they're thinking about drugs. So what's legal, what's illegal, how do you interpret the law, judicial decisions, use of force, like how the police arrest people. But we can think about housing, shelter, and social policy. I have had patients who don't want to go to shelters because the shelter requires abstinence, and if they don't drink overnight, they'll have a seizure. So they're choosing between shelter and seizing. They usually choose to stay outside and continue to drink. But then we can see, that's also very dangerous for them. Resource allocation for services, generally services for people who use drugs are underfunded. City planning, thinking about like hostile architecture that doesn't allow people to lie down on park benches or, no public toilets. We have very few public toilets here in Vancouver. Health spending, school planning, like are you drug testing the football team? Work safe in employment, are you in drug testing safety sensitive positions? Like these are all drug policy issues, but it's vast. It's many arrays of society. But we can say that all drugs carry risk. So whether you're using drugs that are legal or drugs that are illegal, you're taking risk by using drugs. But the molecule itself is just one tiny part of the story. And if you use drugs, the outcome of your drug use is much determined by your race, your gender, your wealth, your social capital, your health status, the purity and strength of the substance, if this is known, and the context of where you use. So when I drink, I like to go to Shambar. I like to have like their cocktail of the evening. It's quite fancy, a beautiful glass at dinner. Like I am very safe there because city bylaws keep me safe. I know what's in the glass that I'm taking because it's labeled by the bottles that the bartender is using. So even though I'm engaging in something that increases my cancer risk, I'm actually much safer doing it than my patient who's maybe 100 meters away using in an alley a shared needle to use fentanyl, because I have consumer protections on my side. So alcohol prohibition is a famous example of horrible policy, right? Like this is Al Capone. He was 26. He was worth 1.4 billion in today's dollars and went to jail for tax evasion. So to think of all the murders, all of the profit to organized crime, all of the people who went blind, all of the infrastructure that was set up for drug supply chains internationally through organized crime is just incredible. I was just reading a textbook about the American War on Drugs, and families in Mexico had vast empires. They're like multinational companies. And that after alcohol prohibition ended in 1933, they just pivoted to the next drug that was still illegal to purchase in the States and used those same supply chains that they had already set up. John Ehrlichman was an advisor to Nixon. He actually went to jail for Watergate. And in 2016, Harper's Magazine did a retrospective about the war on drugs, and they interviewed him. And this is what he said. You want to know what this is really all about? The Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and Black people. You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate the hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Do we know we were lying about the drugs? Of course we did. So even the person that was one of the architects of the current system just plainly says this was due to racism and for political gain, and yet we still have not changed. Sometimes in Canada, we like to think that we're exempt because we're so nice, but historians have demonstrated that drug law in Canada has not been a benign phenomenon aimed at safeguarding the health of Canadians, but a tool of social control directed unevenly at some groups of people. We can see that in a microcosm of the Indian Act and alcohol prohibition for Indigenous people. So Indigenous people living in Canada were prohibited from buying alcohol from 1884 to 1985. It was also illegal to provide an Indigenous person with alcohol in any setting. So if you had someone over your house, it was illegal to give them a glass of wine. And they were barred from entering any licensed establishment with a result of jail time. So this really came to a huge amount of harm when speaking about a group of Indigenous veterans. That when people were serving in the war in France, they were allowed to have alcohol because they were in a different country. And when they returned to Canada, they were barred from the Legions because the Legion served alcohol. And these were the main gathering places of veterans and open to non-Indigenous veterans. So this made like such isolation and such different outcomes for Indigenous veterans because they had much less access to information, benefit programs, and their community. So for Indigenous people in Prohibition, we can see the harm that Prohibition caused to this group of people because they had to consume alcohol quickly to avoid arrest, and they had increased danger when they were drinking alcohol. So 21 things you may not know about the Indian Act says the Indian Act Prohibition set the stage for the pervasive stereotype that Indians suffered from an alcohol intolerance. So this was a policy failure that racism sort of doubled down on to blame this group of people for the harms that Prohibition caused to them. In the current system, we have at least $350 billion per year in the illegal market. It's very much an underestimate. It's mostly through Bitcoin on the dark web. Lots of murders, lots of disappearances. In our current system, over the decades of the war on drugs, that drugs are easier to obtain, they're more potent and cheaper than ever before. And we can really see that clinically. Like fentanyl is so much more potent than heroin. Carfentanil is so much more potent than fentanyl, and it's cheaper. Like I really noticed that fentanyl is a cheaper drug on the street than heroin was. Ken Werb's a wonderful Canadian scholar. He says, contrary to the conventional wisdom that increasing drug law enforcement will reduce violence, the existing evidence strongly suggests that drug prohibition likely contributes to drug market violence and higher homicide rates. And the reason is that organized crime is controlling these supply chains, the product and the price. And so if I entered into business with someone and they ripped me off, I could sue them in a small claims court. But if our business was selling fentanyl, I have no small claims court. I have no recourse other than violence. Then I'm sending someone to drill their kneecaps, right? So we see this violence. I see it in my clinic around the downtown east side all the time. We see organized crime very reasonably switching to a more potent, easier to transport product. So thinking about growing poppy seeds in Afghanistan or Mexico and transporting them to Vancouver, all of the processing and chemical like the chemical infrastructure required to process these drugs, and then they might not even make it to market. You would just lose so much money. But if you can order fentanyl on the dark web by mail, your profit margin is so much higher, even though you're killing your customers. So there's a lack of quality control. We see all of these contaminants, and then that leads to overdose and death. It's a very racist system. The US is the highest rate of incarceration in the world, and nearly 80% of people in federal prison and almost 60% of people in state prison for drug offenses are Black or Latino. You're 50% less likely to have employment post-prison in the States, and 1 in 13 Black people of voting age are denied the right to vote because of laws that disenfranchise people with felony convictions in the US. In Canada, crime has been decreasing, but the number of Black people in prison has increased by 90%. The total prison population has increased, and visible minorities increased by 75%. There was an interesting paper where they did a freedom of information request to 5 Canadian cities to look at police profiling and sentencing, and they demonstrated there was systemic practice of harsher sentencing for Black and Aboriginal people. They use the word Aboriginal there and sometimes Indigenous, depending on the source paper. In Vancouver, Indigenous people make up just 2.5% of the population, and yet accounted for 15.6% of those arrested for cannabis possession in 2015. To me, like there's a lot of really grim stuff in this talk, but to me that's the most grim, because how could it be anything other than racism? Like, you know, there's no plausible deniability here that it's just a broken racist system. Indigenous people account for 26.4% of the federal population, despite representing only 4.3% of people living in Canada. And then Indigenous women are also overrepresented in prison. Susan Boyd again. In Canada and the US and the UK, the majority of women sentenced to prison for drug importation and exportation are foreign nationals, poor racialized women whose choices are framed by global and national political and economic concerns and Western demand for specific substances. I mean, it breaks your heart to think about these women and that, you know, they're just trying to survive. And then they are punished because of our country's drug laws and our country's demand for this product that we have made illegal. I really entered into this conversation as a family doctor. I have a patient population that is in and out of prison, and I know that going to prison increases risk of HIV and hepatitis C. There's interruption in primary care. And then I would see my patients trying to stay out of prison by injecting quickly in unsafe situations, not calling 911. And then after release from prison, there's a huge increase in mortality that is ongoing for a year at least. So when we think about this broken system, we love a U-shaped curve in medicine. So we can make a U-shaped curve. So this is health and social harms. And then this is different frameworks for the relationship between drugs and society. So drugs exist. We have to just acknowledge that reality. Like the UN still is going for a drug-free world, or, you know, a lot of times people have a dream that no one would use drugs, but drugs exist and society exists. And how do we interact? Like, what is the interface between how drugs and society interact that is the safest for people, individuals taking drugs, and the safest for the public? So what we have right now is not at all either of those things. We have unregulated illegal profits where organized crime controls supply chain, the price. They're always trying to get new customers. They're trying to get the customers to buy more. They're profit driven, they're untaxed, they're unregulated. So basically a nightmare. On the other side of a U-shaped curve is another nightmare, and that is unregulated legal profits. This is corporations making money off substances that are addictive. So thinking about tobacco in the 60s and 70s, denying that they had anything to do with lung cancer, advertising with Joe Camel, jazz festivals, like, in magazines from the 80s, we can see advertisements for tobacco, that we don't want like suffering and cancer to lead to corporate profits. Right now for alcohol and tobacco, we are probably down here. They're not regulated enough to optimize public health. That really it should be harder and to get alcohol and tobacco than it is. And that, I think about alcohol labels that are so enticing, or wine columns in the Globe and Mail, or even wine festivals. Like, it's a cancer-causing molecule, and we're having festivals about it. So that really it should be much more tightly regulated to get to this public health space. And that this public health nadir of this curve can look different for every drug. Sometimes when I give this talk, people will say like, oh, well, did you want cocaine to be at the liquor store? No, not really. Like, I think there are many ways that people can access drugs, and that the liquor store is not a great model for it, that it actually, I think about, we had the Stanley Cup riots here in Vancouver, and they closed the liquor stores early, and that probably prevented violence that night. Like, there's just so many public health interventions to keep people safe. So that's sort of been a shift in my career. Like, I'm still providing care to all my patients, but I felt like the scales fell from my eyes, and I was like, well, this is a big structural problem. And I'm staring at my individual patients saying, helping them, I don't think I ever really framed it as like, do better, make better choices, but that's often how the public will frame it. But that actually they're just trying to navigate this incredibly huge structural problem. So where do we go? What is the bottom of that U-shaped curve? So let's talk about decriminalization and legalization. Often the media will mix these up. So decriminalization is paperwork. It is just policy change. It's removal of criminal penalties for possession of drug for personal use to decrease the scope of practice of police. There was a lot of debate in BC about what the threshold should be for what is decriminalized versus what is still criminalized. It sort of is a nonsensical argument because there's no way to know the purity of the substance. So you can have 2.5 grams or 10 grams, but maybe there's the same amount of fentanyl in those two weights of powder. Like, it's impossible to know in the field for that police officer making the choice. Legalization is when drugs are available for purchase, and there's a wide variety of options for how this could look. So thinking about decriminalization, Ryan Marino is a great person to follow on Twitter. I just left Twitter. I thought it was sort of on its last legs, but this one really stuck with me because people who use drugs is a lot of people. When people whose drug use is criminalized, it's not as many people as people who use drugs. And to me, this graph actually represents my social life versus my work life. That I know so many people who've used drugs throughout my life. I think about camping trips, grad parties. Like, I know a lot of people who've done a lot of drugs. And I know 0 people in my social circle of middle-class white people who've been arrested for drugs. But my patients have been arrested for drugs a lot, and they are Indigenous, and they are Black, and they are homeless. And so this idea of decriminalization is just giving the privileges and safety that I, as a white lady, have had my whole life to other populations that have been criminalized because of the same activities that my friends and family have been doing. So it's not thinking about decriminalization as like a hedonistic party where people are suddenly going to start using drugs. Like, probably for my friends and family, their drug use is not going to change because of criminalization, and probably for my patients even, their drug use is not going to change. But what's going to change is that they will not be criminalized. And so Dr. Bonnie Henry wrote a wonderful evidence review of decriminalization. And then so we've had it in BC since February, and data to come, it's going to be interesting. Portugal famously decriminalized drug use in 2001. They emphasized a health approach with increased social supports, harm reduction, and treatment. Drug use decreased, drug use in youth decreased, inmates in prison for drug-related offenses fell, they had no increase in drug-related crime, and they had a decrease in HIV diagnoses. More than 25 countries have eliminated some criminal penalties for drug use, mostly involving cannabis. The limitations of decriminalization are that you have still no control over the supply of drugs and the harms from the supply chain, and you have ongoing involvement from organized crime, and you have no tax revenue. So Canada is a great example of creating a legal regulated market with cannabis. So since 2018, cannabis has been legal, and each province and territory are responsible for determining how cannabis is distributed and sold within their jurisdiction, and they have flexibility. So it's going to be interesting to look at national research about it because it'll be different province to province. And then when we're thinking about what brings safety to a system, like how do we get to the bottom of this U-shaped curve? It's regulation. So it's licensing, standardizing, inspections, supply chain standards, taxes, audits, who gets profits, limits on advertising, marketing, and packaging, price controls, driving restrictions, bylaws and zoning on where you can be sold, hours of sale, bylaws on where you can use, age restrictions, limits. So this is what brings safety. And then you want to balance that with suppressing an illegal market. And then this is where physicians in the room can get rowdy because physicians being psychic is not on this list. That us being the gatekeeper to opiates does not bring safety to a system. How do I know how much drugs someone is using, or why should I be the person's, like it's sort of just this safety theater to say that if a family doctor is the gatekeeper to drugs. And so what does this look like? That we could have a government monopoly, similar to cannabis, that the government is like not making money off drugs the same way a private corporation would. We want regulations to reduce public disorder, expunging criminal records. We want social programs. We want primary care. We want public health. We want social inclusion, housing, treatment, and we want it all. This list grows if you guys have any more ideas. For cannabis in Canada, I think we did a great job. One thing that we didn't meet was who gets the profits, because it's largely white people profiting from the industry, because there was well-capitalized groups who saw this emerging market and took advantage. There is ongoing use of the illegal market, but it has shifted. We've been criticized for lack of expunging criminal records, and there's no formal structure to provide benefits or funding to communities who are harmed by prohibition. I had a moment talking with Donald McPherson. He's the former head of the Canadian Drug Policy Alliance. And we were talking about cannabis, and I was pontificating in my delusional kind of way, one might say, that I didn't think that cannabis should be legal until the age of 25, because that's when your brain has had time to develop. I worry about youth and psychosis. I worry about like cognitive impairments with starting cannabis too young. And Donald, in his sweet, loving way, was like, oh yeah, Christy, absolutely. No, you're right. We don't want youth using cannabis. It's not who you want to see using or not using. It's who do you want to see criminalized. I got goosebumps. Like I'll remember where I was standing like for that moment, because I feel it like really changed my worldview, because I had previously thought that criminalizing substances and not wanting people to use substances went together. But I can want people not to be criminalized, and I can want substances to be legal, and I can also not want people to use drugs. Those are not contradictory statements. I want that youth to not be using drugs, and I also don't want them to be arrested for drug use. Those are both true, and they're not in conflict. This is a real moment for me. So really, what I have been thinking with this overdose crisis, as we're struggling to meet the needs of my patients who are just dying so frequently, is that we're struggling to find a medical solution to problems that are created by the criminal justice system. So we're already starting on the back foot, and probably not going to succeed, really, because the criminal justice, our own government is making these problems. And then I was thinking more about medicine and drug policy. Like, what is our role? We know substances can cause harm, and like there's definitely times where someone needs us if they're having a seizure or, they're on their way to the ICU. Like, what can we offer as physicians? And then I think about alcohol. It's legal, but it's dangerous. Most people have no problems with alcohol, but some do. But they can always access alcohol that's drinkable. And if they're drinking Listerine, they can access our managed alcohol program. But then I want them to come to me for naltrexone or a camprosate and their liver enzyme check and their flu shot and their Pneumovax. Like, that I want to do the medicine of it. But somehow with opiates, we're stuck sort of in this middle place. I also thought a lot about the medical model of addiction, because I'm very skeptical of it. this idea that it's relapsing and remitting and permanent and lifelong. So once you have the diagnosis of substance use disorder, you have it for life. I have to say that always made me uncomfortable to say like, oh, you've got severe alcohol use disorder in remission. Even if you haven't had a drink in 20 years, that we're still labeling people with a medical issue, even it just seemed wrong to me. And Leslie McBain told me once, we've pathologized drug use and we've medicalized well-being. I think about the DSM criteria for substance use disorder and how flawed it is. And the one I especially think about is the one of spending a lot of time getting, using, or recovering from the substance. And I think about rock stars. I have to put an anonymous. I've never seen this movie. I don't even know if it's good. But certainly many rock stars use a lot of drugs. And they would have a full-time person maybe acquiring their drugs for them. So they're not spending much time getting their drugs or recovering from their substance, because maybe someone comes and like hangs a little IV bag to hydrate them after their drug use. Like that, because of their wealth and their social position, they are shielded from having this tick box on a DSM criteria. And so how can we sort of say this is like a psychiatric condition when your wealth is protecting you, whereas my patients who are binning all day long to try to get their drugs would get this tick box? To me, it speaks to the social determinants of health rather than like an actual illness. So then I was thinking, okay, so we were trying to respond to this overdose crisis as clinicians, and that if there was a winery that was poisoning people, our expectation would be that the government would shut the winery down, that they would lose their license to sell wine, and then the problem would be resolved. But what if instead the government said, okay, wine is now free, and you need to go to your family doctor, and you're going to get your free wine from your family doctor. And that if people kept going and drinking the poison wine because they like it better, and then people were like, oh, family doctors are just not prescribing enough free wine. And then people were coming to our clinics being like, give me more free wine. And I was like, oh my God, okay, well, I'm prescribing wine as fast as I can. And there's still overdoses happening because the winery hasn't been shut down. Like that's what's causing the problem. And it shouldn't be primary care that's like trying to prescribe wine to replace the poison wine. So, I mean, all that to say, like, that's what I've been doing, basically. So for safe supply programs at the PHS, we're doing methadone, Suboxone, and Sublocade. We have IOs, we have a fentanyl patch, and we have fentanyl powder. And these are been embedded in over various places over various years, overdose prevention sites, pharmacy, housing, a standalone facility, and clinic. And it's all off-label other than the OAT and IOT. So I had found some clinical challenges with the shift in the drug market. I'm just going to do a little time check. Okay, so that the dosing for traditional OAT wasn't working as well. I had patients on 150 of methadone still having overdoses. Patients were requesting fentanyl, which made sense to me. Like when we look at the IOT literature for heroin, they were replacing heroin with heroin. I did IOT, I replaced heroin with hydromorphone and worked medium. But the drug market had shifted. So I felt like my clinical interventions had to also shift. How to meet the needs of smokers and how to meet the needs of the non-daily drug user. Fentanyl is a challenging molecule that the formulations of fentanyl that existed before we did this work didn't have adequate dosing, reasonable delivery mechanisms. Like in a way, they would have a huge barrel of Sufentanyl, and that we weren't like in the ICU to hang many bags. Fentanyl, the molecule is large, requires a large amount of liquid in solution, but the physical granule is very small. I really understood more after going through this process of how hard it would be for organized crime with their blend tech, like mixing up baggies of fentanyl, that it would be so varied, the dose from baggie to baggie, because even within our NAPRA certified pharmacy partner, we had to reject a batch that they had done because it didn't meet quality testing on external validation. So we created this new fentanyl protocol that we wanted powdered fentanyl, so it's a long shelf life. The person mixes it up themselves to cook. It's in pre-filled capsules at fixed doses. We purchased fentanyl powder from a national pharmaceutical company, and then we worked with a local compounding pharmacy to create this new vehicle to deliver fentanyl. We color-coded the capsules. We launched about a year ago. It's a high-intensity medical model. It's 4 doses a day, all observed, and it was very successful. Patients report it's working very well to replace their street supply. We adjusted a lot based on patient feedback. So every week we did a survey for all the participants. And basically the question was, are we there yet? And they gave such specific feedback. I was delighted and surprised at how specific the feedback was. So we went down on our caffeine, we switched the dextrose to mannitol, we changed our ratios, we changed our titration schedule. So the first dose for the first patient, I started at 250 micrograms of fentanyl. I thought that was a pretty good dose. And our starting dose now is 10,000 micrograms of fentanyl. I wish I was there in person. I could hear you all. I never thought I'd write starting doses for 10,000 micrograms of fentanyl. And this is, of course, off-label. So this program was running well, chugging along. We have 23 spots on the program. It's an expensive program for 23 people, but they are doing so well. Getting your Hep C treated. You know, we do vaccine blitzes, primary care. They're really teed up. They look great. And so here I was running this program and thinking, okay, well, this is great for these 23 people, but like, how many people need this intervention? Like, how many people are at risk of death in BC from overdose? And it's about 100,000, we think. So then I was thinking, okay, how do I make this bigger? And the infrastructure is a huge part of that, and the drug cost is a huge part of that. So I looked to the literature. I had a librarian do a literature review for me, and I asked, what is the impact of pricing on alcohol and tobacco? And there is a wealth of evidence to show us that the higher the price of alcohol and tobacco, lower morbidity and mortality. And so price is an important public health intervention when thinking about drugs. So I thought, I'm going to apply that to my fentanyl powder program. So this sales arm runs in harmony with the high intensity medical model, and people can purchase fentanyl powder for take-home dosing. So it's not covered by pharmacare. It's a new formulation of fentanyl. So it's not covered. And so the workflow for this new program is the same as everything else. It's nothing new. You meet the doctor, you do a urine test, a history physical. Once you press go, they titrate with the nurse. So it's the nurse observes the dosing. So it's similar to, if you could imagine, every liquor store had a nurse there, and that you had to get a titration tolerance test before you're allowed to buy any alcohol. And I would be on my second drink, and the nurse would say, "Oh, Christy, that's enough for you. You get 2 drinks a week. Choose wisely. You get weekly dispensed 2 drinks. You pick out your 2 drinks to buy." This is what we're applying to fentanyl. So there's a decision support tool that the nurse has. They work closely with each patient, and the patient says, okay, this is my dose. It's 8 doses over 2 days if there's no missed doses, but people can sort of spread it out depending on how chaotic their lives are. It doesn't have to be 2 days in a row. So if you're working, you can come a Saturday and a Saturday. And then a patient-specific duplicate prescription is created for each dose. When they're done the titration, I generate a prescription for them and send it to the pharmacy. So we make no revenue from the process. It's a cost recovery framework. So we have 2 locations. We sell them from our pharmacy partner, just as the sales directly. But we also sell it out of our clinic, where we act as the patient's agent to purchase on their behalf, and then recoup our costs from the patients themselves. The physicians and nurses, we just make a standard rate. We have no revenue. So the patient can present to our clinic or the pharmacy to purchase their medication. Everyone is on daily dispense so far, but I look forward to starting people who are the occasional user. So if someone's using weekly or monthly, they could be on a monthly pickup schedule, depending on their dose, the context of their life, and all of those clinical considerations. They can prepay to have a tab. Family members are often involved. People have done really well in our program who have parents who can come and purchase the drugs on their behalf. And we can take cash, e-transfer, credit, or debit. There's an option to partial pay. So we wanted to have it for a lot of our patients. They would get some money and then go and buy drugs, and then get more money and go buy more. So we wanted, you don't have to buy it all or none. They give the drugs as per the prescription payment. All the doses are take home, and all the medications are labeled at the pharmacy with the patient and medication information as the college requirements. And the patient will actually get a receipt, which was just like such a thrilling part of it. They love getting their receipts. And so this program is sort of business as usual. Like, it's just a physician writing a prescription that someone gets from a pharmacy and pays for. But what makes it different is that it's fentanyl powder. And so the cost is on par with the illegal market. So $25 for 20,000 micrograms. It might be a little bit more expensive, but we're working on getting the price down. I hope to get it down to 20, but it's based on, as we increase our volume of sales, Mediska will give us a better price. I think that the price decreases risk of diversion, because we can see that for like alcohol and tobacco, looking at that literature for harms in society, that the price is protective. There's no money to be made by hijacking this program. So if you bought your drugs from me, you couldn't then resell them for any profit. But there's significant benefit to the patient with the drug dose and purity. So this is a great intervention for an occasional user. And this is the first time we've actually known what is being sold on the street, because before we had the drug checking data, but it wasn't enough to like take that drug checking data to extrapolate what a pharmaceutical product would be. So now we know that a point of fentanyl is about 10,000 micrograms. So after initial titration, all the doses are take-home doses. So it respects people's autonomy and flexibility, less operational needs for staffing and space, and quite scalable. So just to sort of summarize, I've got these two interrelated programs. So the medical model, SUAP funded, is all witness doses. People can go up to 25,000 QID. SUAP pays the drug costs, and it's paired with OAT pathways to recovery. The sales program, Enhanced Access, is all take-home doses after the initial observed titration. We chose 20,000 micrograms as our selling point because it most matches the percentage fentanyl purity of the drugs on the street. So we didn't want to sell something that was too over or too under what the equivalent amount of powder would be on the street. The participant pays their own drugs. It's a lower intensity model with a variety of dispensing schedules and also paired with OAT and recovery. So for safety features, there's a robust intake with a physician, the titration period that's individualized for each person. You're connected to primary care and OAT, and then low barrier supports. We're being evaluated by the BCCSU. There's extensive policies and procedures, and we had a legal review by RFA Finlay. So we meet all federal and provincial requirements for all three colleges, so nursing, physicians, and pharmacists. So a program will never solve a problem that's been created by policy. It has been something, it was like a knife to my heart when my friend told me this. I was like, oh my gosh. But it's so true that I've been creating all these programs for my career, and they were going well. They were a joy to deliver. They went really well for my patients, but I was trying to solve policy problems. And so my hope is that this program solves a policy problem. And then I've been thinking a lot about this, that I think that as clinicians and the public and all of us, government, we get these things entangled in what problem are we trying to solve. So to me, I've tried to frame it for myself as there's an economic problem. It has to do with supply chains and consumer protection, that there should be bylaws for safety for purchasing drugs, all drugs. Then there's a medical issue, that if someone has substance use disorder, I want to see them and I want to treat them well. So for OAT, primary care and recovery. And then there's the social determinants of health, housing, food security, and poverty. And sometimes we mix these issues up. And I think as well in harm reduction, often you are, not personally, but harm reduction is burdened with more solutions than what it intends to address. So I think about Insight. Insight's job is to do clean needles in supervised space, so you get less HIV transmission and less overdose death. Tick, tick, success. But if you look at the street outside Insight, Hastings looks terrible. Like it looks like a movie set almost. Like it's so depressing and sad. And so people will criticize Insight for how Hastings looks, but it's not Insight's job to do that. Insight is doing its job, but it can, like many harm reduction projects, be burdened with more outcomes than it's meant to take on. So I think about that for my program, that I am trying to have a really narrow scope with this program. I'm solving an economic issue. I'm not solving the medical issue with this program. And then I'm not solving poverty. So I've thought a lot about this as well, because a lot of times when I'm talking with people, they worry about their patients who are living in poverty. How would they afford these drugs to take home? And I do feel for those people, and I feel for my own patients, but that if we want to solve poverty, we have to increase disability checks. We have to have low barrier housing with reasonable rent, not be in this terrible housing bubble that we're here in Vancouver. So we have to have low barrier employment, people being paid a living wage. Like giving out free drugs is not a solution to poverty. And me charging for my drugs is what gives me safety as a clinician for giving these take-home doses of fentanyl that is so potent that it would be so dangerous in diversion. So I also stress about poverty for my patients, but that I don't look to this program to solve that. I am just concentrating on economics. And then at the same time, I'm still a family doctor, so I'm doing primary care and OAT. So just in conclusion, the world doesn't have to be set up the way it is. Like we can envision a different future, and we can be really angry about it. I don't know you guys, but I am. And that I am delighted to be part of a community that is helping to form a better future. And that this is a long journey. Like I always think things should be fast, but there's a lot of lawyers involved and they're slow. But I guess that shouldn't be surprised. If you're trying to build a legal regulated market, there's a lot of legal things involved, and I'm lucky to have such a wonderful CEO who's a lawyer. Okay, that's it.